Mr. the Chairman, ladies and gentlemen, dear colleagues, I'm very happy to be here because first, it's my first stay in Israel, and second, I am really honored to be invited by the scientific organization. So when we look to the cardiovascular assessments of athletes, we have two main questions. First, can we prevent sport-related cardiac sudden death? And second, can we detect silent cardiomyopathies that can be worsened by intense sport practice? When we look to the causes of sport-related sudden death, you can see that we have two places: before 35 years old, after 35 years old. After 35 years old, it's coronary disease. That is the main cause of sudden death. And before, you can have some channelopathy or several genetic or acquired cardiomyopathy. So we can see, and it will be the topic of the next lecture, the place of the UCG for channelopathy and the place of cardiac imaging for the other disease. However, when we look to the cardiac imaging place in athletes, we have, I think, two main issues. First, the low prevalence of sudden death risk cardiac disease in athletes. It has been estimated about 1 to 200 athletes. So we can say that cardiac imaging in athletes has a second-line place in the strategy of sudden death prevention. And for example, we had the opportunity to make a study in high-level French athletes, more than 4,000. And all these athletes had history, physical exam, and resting UCG. We detect abnormality in about 4% of these high-level athletes. And all the athletes had also echocardiogram, rest echocardiograms. And you can see that we have only a small augmentation of the abnormalities. So we think that in this case, we cannot propose echocardiogram for all the athletes. Second issue concerns the pattern specificity of athletes' hearts. It means that we must have knowledge of specific signs of athletes' heart. The main athletes' heart patterns are summarized on this slide. There are UCG particularities, structural particularities, and functional particularities. These two adaptations can be well screened by cardiac imaging. So we begin with a standard echocardiography. And here you have an untrained guy, and here a professional cyclist. And if we can summarize, we can say that concerning resting standard echocardiography, you can accept a moderate and harmonious dilatation of the four cardiac cavities with a slight hypertrophy associated and normal or improved systolic and diastolic function. However, it's not so easy because we know now that we can have some ethnic specificity. And concerning the left ventricle, you can see work of our group. We had the opportunity to compare Afro-Caribbean professional soccer players, Caucasian soccer players, and Japanese soccer players. And you can see here African is in white, Caucasian is in gray, and Japanese is black. You can see that when you look to the left ventricular internal diameter, the most dilated heart is observed in Japanese soccer players. And when you look to the left ventricular wall thickness, you can see that the more marked wall thickness is observed in African Caribbean soccer players. So in function of the ethnicity, you can adapt your normal values. It's the same concerning the right ventricle. And when you look to this paper coming from the team of Sanjay Sharma, you can see that when we look to the criteria, the major criteria of arrhythmogenic right ventricular cardiomyopathy, you can observe in more than 30% of male athletes, 20% of female athletes, criterion of major disease. So you can see that sometimes it's not so easy to say it's an athlete's heart or it's a cardiac disease. So when we look to the value proposed concerning the limits of athlete's heart, in most cases, the diagnosis is easy, but in some cases, and mostly in Afro-Caribbean athletes, but also in Caucasian athletes, about 3 to 4%, you can ask questions concerning dilated left ventricle. Is it a dilated cardiomyopathy or arrhythmogenic right ventricular cardiomyopathy? Concerning the wall thickness, is it hypertrophic cardiomyopathy? Concerning abnormal UCG, and concerning complex arrhythmias, is it myocarditis or other cardiomyopathy? So we see that in case you have a doubt about the first echocardiography, you must use other techniques. We have now new echocardiographic analysis methods, and we can see together some of these methods. First, about the left ventricle normals to the strain values in athletes. Here, this paper is coming from the group of D'Andrea, and it has been confirmed by the group of Bordeaux. And you see that in more than 600 athletes, you can observe that there is, in endurance athletes, not in strength athletes, a decrease of the values of the strain in these athletes. And these two groups say that about 19% of athletes showed a decrease of left ventricular global strain, longitudinal strain, less than minus 16%. When we compare now the data obtained in athletes with cardiomyopathy, you see, this work is coming from the group of Bordeaux. You see that you have a decrease of the values in athletes in comparison with controls. But when we look now to hypertrophic cardiomyopathy, you see that the decrease is very more marked than in athletes. So here it is an example of a professional football player with no symptom, no familial history, and a normal UCG. You see, you can ask some question about the left ventricular wall thickness on these athletes. And when you go to the... Oops, sorry. When you go to the strain, you see that the adaptation of the strain is quite normal. Now, if we look in a patient, an untrained man with a family history of hypertrophic cardiomyopathy and abnormal UCG, you have a quite similar echocardiography, but when we look to the strain, you observe a real decrease of the value of strain. So now we may use exercise echocardiography in athletes because it can help us in several cases. For example, here is a very high-level trained cyclist with a dilated left ventricle, and you can see that you have a small decrease of the strain on this place, but we can ask some question. So when we look to the value we have now, normal values concerning exercise echocardiography for left ventricular strain, you see first that you must observe a great increase of left ventricular ejection fraction, as it is showed here, and you have also an increase of the myocardial velocities and myocardial deformation. So when we go back to our cyclist, you can see that during during the if you compare the rest echocardiography and the exercise echocardiography, you can see that you have a good increase of the ejection fraction in this case. And when we look to the strain, you have also a good increase of the strain during exercise echocardiography. So exercise echocardiography can help us. And it is the same for the right ventricle when we look to the data from Lagersh. So we can conclude that in high-level trained athletes, a low strain and strain rate measurements during rest echocardiography should not be interpreted as a sign of subclinical myocardial damage. You must use exercise echocardiography if you have any doubt. So let's go now to the cardiac MRI. And we had the opportunity to make a study concerning the T-wave inversion in athletes. T-wave inversion in athletes is a very important issue, a current issue in athletes now. And we had the opportunity to study 155 asymptomatic athletes with abnormal UCG. You can see the pattern of abnormal UCG in these athletes. And you can see when we do echocardiography, only echocardiography, we have 180 normal people and only 33 cardiomyopathy. When you add cardiac MRI, all these subjects add cardiac MRI, we can increase the number of cardiomyopathy about 24 cardiomyopathy. And we add only 94 normal athletes. Then we add exercise test, alter, and follow-up, and we can detect 8 more cardiomyopathy. So we see that when we have T-wave inversion, even if you have a normal resting echocardiogram, I think that you must perform cardiac MRI in these cases, in athletes. However, it's not so easy to compare the normal values in MRI and in echocardiography, because here you have before training in a group of 22 subjects who train. Before training, you can see that the values of wall thickness and the values of left ventricle dimensions are not the same in echocardiography and in MRI. And it's the same after training. So we must use the specific values that is proposed in the literature for the MRI interpretation in athletes. The second point, the second issue with cardiac MRI concerns the delayed gadolinium enhancement that we can observe in athletes. This example, coming from the paper of Lagersh, showed one healthy endurance athlete. We say healthy, but we are not sure because everything is normal except the delayed gadolinium enhancements. And in this other case, you have also, it's not really clear, gadolinium enhancement here, and this athlete had an aborted sudden cardiac death. So sometimes we can observe a gray zone concerning cardiac MRI like in echocardiography. Lastly, only a few words concerning the coronary artery calcium scoring and CT coronary angiography. Concerning CT coronary angiography, it can be used when you have questions about anomalous coronary arteries. And concerning the coronary artery calcium, I know that US colleagues propose to do coronary artery calcium scoring in athletes after 35 years old, athletes who want to make competition. However, it can be controversial because we know that all these athletes are asymptomatic with a low cardiovascular risk. And we know that it is really difficult to interpret coronary scoring calcium in this case. So we can ask some question about the real value of systematic screening by coronary artery calcium scoring in these people. To conclude, if we want to prevent sudden cardiac death in athletes, and when you have an asymptomatic athlete with no family history, I think that, and it is the French recommendation, the French Society of Cardiology recommendation, the first line, however, it is controversial, and it is the topic of the next lecture, we can propose 12-lead UCG. If it is normal, you can give clearance for competitive sport. If you have an abnormal UCG or a doubt concerning UCG, in second line, you can propose resting echocardiogram with all the new methods, analysis methods. And if it is normal, you can give clearance. Question concerning the T-wave inversion, as I showed you coming from our data. In the third line, if you have no clear diagnosis from echocardiogram or T-wave inversion, you can propose cardiac MRI. If it is an athlete's heart, or if it is normal, you can give clearance. And at least, if you have a doubt, is it an athlete's heart? You can propose follow-up or day training, even if it is not so easy to propose day training in a high-level trained athlete. If you have questions about coronary arteries anomalous before 35 years old, you can propose CT coronary angiogram. And after 35 years old, maybe you can propose stress test, exercise test, or calcium scoring. Thank you for your attention.
Thank you, François. It's a very complete talk about that topic. I'm sure there will be some questions in the room. So you told us, well, first ECG, we'll speak about that later, 2 resting echo, okay? Then if it's doubtful, go to exercise echo, and then if it remains a doubt, go to MRI in the young, right? So what is a doubtful echo? That's the first question. Do you take the threshold of 13 millimeters? Above that, it's doubtful, 13 or above. And do you take a threshold of 55% ejection fraction? Do you take a threshold of 60 millimeters of dilatation? What are the thresholds for doubtful echo?
Well, it's an important question. First, I think that you must interpret echocardiography. First, you must look to the left ventricle diameter. If you have a large left ventricle diameter, you can accept 30 millimeters of wall thickness. If you have a small left ventricle diameter, you cannot accept 30 millimeters because it is not normal to have, for example, 45 millimeters for diameters and 13 millimeters for the wall thickness. Second, when you look to the left ventricle fraction, ejection fraction, you must interpret all the data. First, how is the heart rate of the athlete? Is it a low heart rate, about 40 beats per minute, for example? If you have a very large left ventricle with a low heart rate and a slight decrease of ejection fraction, you can say it's physiological adaptation. Because we forget that the adaptation for athletes' hearts concern exercise, not rest. So what we observe to rest is not predictful for what we will observe during exercise. So I think that you can accept 50% of ejection fraction with a low heart rate and a large and a dilated left ventricle. And lastly, you must also have an interpretation concerning the ethnicity, because we think that in black athletes you can accept until 15 millimeters for the wall thickness if the left ventricle is higher than 55 millimeters. So it's not so easy to give clear threshold.
I think you're right. We did a study on the athletes of the Tour de France, bicycle, and in fact less than 1% have a small ventricle, less than 55 millimeters, and above 13 millimeters for wall thickness. And conversely, ejection fraction was low in more than 5% of all patients, less than 55%, but always with a quite enlarged left ventricle. So I think you're right. What about late enhancements? Because you told us that in some athletes, you might have some late enhancement within myocardium. And you say it might be normal. For me, it's not normal.
We have a lot of questions about the late gadolinium enhancements. And for example, I can give you two new data, very new data. One data where late gadolinium enhancement looks like chronic myocarditis. It was professional soccer players in France. So we give clearance for him, and he plays during 5 years without symptoms. And just when he wants to stop his career, he has palpitation. And now we must put him an ICD because it was ventricular tachycardia.
So it was an abnormal heart?
It was an abnormal heart. And the second one is a professional cyclist with the same evolution, but only about after 6 years of follow-up. Currently, the recommendation says that if there is no symptom, you can give clearance. we discuss about this point, but it's not so easy.
Well, I will not do that, but is it one question or two in the room? If there is.
I just want to, can you clarify a little the role of strain imaging? Is there a situation where the echo is normal, but just based on strain imaging you make a diagnosis? Or?
No, you're right. I forget to say, this is a very important point to my opinion. You must do standard echocardiogram. If standard echocardiogram is strictly normal, you must not use strain. Because if you have a small decrease of strain, you will ask a lot of questions, because you see that the normal value are not the same in athletes than in untrained people. So, to my opinion, and we agree with André Laguerche, that you must do normal standard echocardiography, and only if you have a doubt about ejection fraction, you may use strain evaluation. We have no clear explanation about that. When you look to blood pressure, resting blood pressure or exercise blood pressure, we do not have differences in these athletes. And you know that we have also a specific adaptation on UCG with a particular pattern of previous repolarizations. And we have no explanation currently about these adaptations.
And also, if you look at the causes of sudden cardiac deaths in athletes, in fact, black people are dying twice from hypertrophic cardiomyopathy as compared to Caucasian. So, I mean, 50% of sudden cardiac deaths in athletes, in black athletes, are due, in fact, to hypertrophic cardiomyopathy as compared to 25 to 30% in Caucasian.
My name is Malka from Israel. I would like to ask if you would add to the routine evaluation for sport echocardiogram, because in our country, according to the sport law, we have the routine examination and ECG. And I'm in this conference presenting a case of a young person, sportsman, which this year I was asked by him to renew his permission to take part in sport. And his ECG and the examination was okay, but I don't know why, it's just for feeling. I sent him for an echocardiogram, and it was after a week or two open heart surgery for a hemangioma of the heart. So I decided everyone to send for echocardiogram. What is your attitude? It should be a routine because it's simple and not cost so high. It's not like MRI, etc.
Well, in France, we have for all athletes UCG and medical exam. For high-level athletes, the law said we must perform echocardiography. However, as I showed to you, I think that echocardiogram, systematic echocardiogram, is not really interesting for all people who want to do sport. And I think that it is not necessary to propose systematic echocardiograms in all athletes.
Thank you very much. We have to move forward. The next speaker is Sami Viskin from Israel, who's published a lot on athlete screening, and he's going to discuss controversies in cardiovascular screening of athletes. Sami.
Thank you, Michael. Thank you for the invitation. So my role is to talk about controversies in cardiovascular screening of athletes. And there's many controversies, but I just selected a few. The first controversy is how common is it, sudden death in athletes? The second one, is sudden death more common in athletes than in non-athletes? Then we'll move to ECG screening, to mandatory ECG screening. Does it really save lives? Have we proved that ECG screening saves lives? And finally, if I have time, I will enter to the controversy of how much does it cost. So to the first point, how common sudden death is in athletes? Well, it depends who you ask and depends on the studies as you look. But we all agree, most of the studies agree that this is a rare phenomenon ranging from 1 in 100,000 to 3 in 100,000 person years. But there are studies from the US that you have seen that in particular athlete population in elite male athletes playing basketball in college, especially if they are from African American origin, you can reach much higher numbers of 30 per 100,000 person years. But most of the studies are around these figures, which is showing that it's a very low rate event. The second question is very important. Is sudden death more common in athletes than in just people? And this is a very critical question because the whole basis, the moral basis for screening athletes, and not to screen people like me who are not athletes, is the assumption that the sudden death rate is higher in athletes than in non-athletes. Otherwise, it is difficult to justify screening one and not screening the other one. Well, here again, the answer is depends who you ask. In Italy, and that's the numbers that everybody uses as a basis for this assumption, sudden death in athletes appear to be 3 times more common than in non-athletes. But in a very good study in Denmark, it is actually the other way around. The study in Denmark is very important. They used, in Denmark, they have a law where the death certificates must be very specific about the mode of death. In Israel, I don't know if you know, but when you die, your heart always stops at some point. And everybody uses that to write the causes of death as cardiac arrest. So the certificates in Israel and in many parts of the world are totally useless. But in Denmark, they have a law that when you sign a death certificate, you have to put all the medical documents and you have to be very accurate about the cause of death. And based on that, they were able to publish a study, and they showed that sudden death was actually lower in athletes than in non-athletes. Now, I'm going to be spending most of my time trying to answer the question, does ECG screening of athletes saves lives? Is that a proven fact or just a wishful thinking? Now, and so what is the definition of an intervention that saves lives? To really define an intervention as such, we must have a randomized studies in which a very large patient population is randomized to either undergo screening or to not undergo screening, and then we follow up for 10 or 15 years, and we show that those who underwent screening have a better survival. And we have studies like this, but they have nothing to do with sports. For example, if colonoscopy is a procedure that has been shown in many studies that if you, by randomized studies, that if you do colonoscopy to asymptomatic individuals, you will decrease the mortality from colon cancer. But there is not such a study for ECG screening in athletes. So when we say ECG screening of athletes, what level of evidence are we talking about? We have class 1 level for randomized studies. When we say ICDs save lives in patients with low ejection fraction, we are mentioning we are basing that on several randomized studies that show exactly that. When we say that ECG screening saves lives, we're basing ourselves in one non-randomized study from Italy that I will show you, and on expert opinion, which is more or less like saying because I say so. Now, there are many studies showing that if you do more screening, you will find more disease. Like this in Annals of Internal Medicine, if you only use medical examination, you will find a small number of abnormalities. If you use ECG screening, you will find more athletes with abnormality. And of course, that makes sense. And if you use echocardiogram, you will find more. And if you use MRI, you will find more. And if you use PET-CT or whatever, you will find even more. But to assume that all the patients that you find with additional screening are patients that should be counted as life saved, that is wrong. Because one thing is to diagnose disease, and a very different thing is to improve survival. And we have learned that the hard way through PSA screening for prostate cancer. If you do PSA screening for prostate cancer, you increase the detection of cancer detection by 12%. And many individuals underwent biopsies and prostatectomies and suffer a lot, and they think they were saved by the screening, but the truth of the matter is that in a randomized study of a randomized study of PSA screening versus no PSA screening with a very long follow-up and thousands of patients, there was absolutely no survival benefit for PSA screening, even though we diagnosed more cancer. So is there any evidence suggesting that ECG screening saves lives? Well, there is only one study, and you know this very well. It's a very famous study from Italy, showing that once they started screening, the mortality of the athletes went down dramatically. Now, there are several problems with that study. The first one is a bias that is called Immortality Bias. The design of the study is that patients were screened at a given point in time when they were 18, 20, 22 years old. Now, most of these individuals, those who have disease, the disease has been present from birth, so it is possible that by the time they're screened here, many of those who had the worst form of the disease were already dead. So there is a bias. You have to survive long enough to reach the point where you are screened in order to, you have to survive to get screened, so you end up with a population that has a less severe form of the disease. So if you then compare the mortality here before screening to after screening, you will have a strong bias into showing a beneficial effect, even if that effect does not exist. Now, if you notice, in the Italian study was a forensic study. And as you know, you have to die to undergo a forensic examination. So patients who had a cardiac arrest and had a successive resuscitation do not appear in this slide. So is it possible that one of the effects that we are seeing in this slide is that we got better in resuscitating athletes during the later period of the study? Take, for example, this study, just to prove the last point. This is data from marathons in the Twin Cities in the United States. It's data for almost 500,000 athletes participating in the marathons, and you can see that the rate of sudden cardiac death decreased significantly during the course of the years. and this is a population that did not undergo ECG screening. However, if you look at the rate of successful resuscitation over the years, you can see that it actually improved. So if you look at the rate of cardiac arrest events, including fatal and non-fatal events, you see that there is actually no difference between the study periods, and it is only when you looked at the those who actually died, like in Italy, you get the impression that there is a significant reduction in mortality, and again, this is a population that does not undergo ECG screening. Now, if you notice in the Italian study, so this is where the screening started, and they show the decrease in mortality, but they only compared this very long follow-up period with only 2 years of pre-screening, and you can see that the mortality was actually going up and was in its maximum point when they started screening. So perhaps what we're seeing here is not that they reach a very low level of sudden cardiac death, but perhaps they had the advantage of starting with a very high incidence of sudden cardiac death that perhaps was too high for what's really the truth. And I say this because if you compare, so this is the Italian study that I just showed you in yellow. If you compare the mortality rates to other studies that I put here on the slide, including data from the US, from Denmark, from France, and you can see that the mortality in all these athletes without screening is in this area, which is more or less similar to the mortality in Italy after screening. And so this suggests that the point that we are seeing here is artificially high just by accident. In Israel, there is, at some point, we also had a law mandating ECG screening for all athletes, and we looked at the effect of this law in Israel, the mandatory ECG screening, on the mortality of athletes. And you can see that if we compare if we look, the screening was started here. So if we compare the mortality 2 years before screening to more of 10 years of screening, you get a figure that is very similar to the one shown in Italy. But we actually looked to a longer period, making the pre-screening and post-screening periods of the same duration. And you can see is that the truth is that there is no effect on mortality. So there is a high year-to-year variation that reached the point here, and this high point is probably what triggered the noise in the media that led to the initiation of the law, and then we got the decrease in mortality that was just back to what it was before. This is another paper from Barry Maron, recently published, showing a data collected over 10 years for more than 4 million athletes, verified by autopsy. And if you look at the variation from year to year, you can also put a graph that is very similar to what we saw in Italy. And this is just by accident. Just by accident, we get the same event, the same effect. Now, we can get a good idea about the effects of the screening on saving lives by looking at the results of the screening. In other ways, if you do screening, you do a diagnosis, then you have to do an intervention that will save lives. So when we talk about ECG screening, the intervention is disqualification from sports. So if you look at the reason why were the athletes disqualified, you can get a good idea of the importance of the intervention. So we looked at the reasons for disqualification of athletes in the famous Italian study. They're shown in yellow there. To see the yellow, you have to have very good vision. I'm sure you cannot see what's there, but I'm going to read it for you. So the reasons why athletes were disqualified in Italy were the following. 23% were disqualified because they had arterial hypertension. That has not much to do with ECG screening. The other 39% were disqualified because they had arrhythmias during an exercise test that caused symptoms including dyspnea and syncope. So you want to tell me that these were completely asymptomatic athletes that had symptoms during the exercise test but do not have symptoms during when they do their sports? Is difficult to believe. So this is a selected population who was disqualified because of symptoms, because of exercise-induced symptoms. So you can see that disqualification from sports truly due to asymptomatic ECG abnormalities occurred in only 38% of the disqualified athletes. Finally, even let's assume you still believe that ECG screening saves lives. After all what I've told you, how much will that cost? Well, again, there is a controversy. The paper that is quoted more frequently is this one by Wheeler, published in Annals of Internal Medicine. They took the numbers from the Italian study, before and after, before screening versus after screening, and then they did a lot of mathematical assumptions that I don't understand. I doubt it all the authors understand, probably just the first author. And they got to the conclusion that ECG screening, the cost is for saving one life year is $76,000, which is fairly decent. Now, it's very difficult to understand this paper, but one thing I understand that is wrong, is fundamentally wrong in this paper, is that one of the assumptions that when they took the Italian study, they assumed they screened the athletes only once, when in Italy, they screen the athletes every year. So to get the number of athletes saved, they had to be screened over and over for 12 years. So the price should be actually much higher. You have to multiply it by 12. So we did a different analysis. We published that in JACC 2 years ago. Again, we looked at the Italian study. So this is the mortality of athletes with screening. We assumed that the mortality in athletes without screening would look like this. So we calculated the difference in mortality between screening versus no screening. Then the Italians also published the percentage of athletes that underwent additional examinations like echocardiogram in 9%, exercise test in 3%. So we knew the test that a large population of athletes would have to undergo if they behave like the Italian population. We have the prices from the different tests. We use the prices used in Medicare in the United States. And based on the number of tests, we calculated the entire price. Now, we know the number the actual number of athletes that were saved by screening by calculating the difference between the red graph and the blue graph. So finally, you can get that through all the process of screening, you save almost 5,000 athletes. And then by simple mathematics, our conclusion is that the cost for saving a life in the United States, if the population there would behave like the Italian population, would be between $10 million to $14 million per life saved. Now, just to put all this in a different perspective, I want to show you data from a paper that is in press in JACC. We looked at the mortality of all the marathons that have taken place in Tel Aviv over the last years. It's a good way. You have to register in advance. You have to, if you don't get the right shirt, you're not allowed to participate. So we know the numbers who participated. I am there with the wrong shirt just because it's from a different year. I did pay my subscription, and we know the number of athletes who had cardiac events because our hospital is somewhere near here, so the entire race is around our hospital, so all the athletes who have cardiac events are transferred to our hospital. So we have data for 130,000 runners who participated in the Tel Aviv races for the last 6 years, and we had only 2 cardiac events that were not fatal. One was a myocardial infarction, one was a supraventricular arrhythmia. On the other hand, these are the numbers of very serious events. By serious, I mean either fatal or near fatal. They had to be intubated, going into respirators, into intensive care, and this is because of heat stroke. So you have to, this puts in a different perspective the whole idea of ECG screening, because it shows you that at least in areas like this, heat stroke is a more serious problem than cardiac conditions in athletes. And I will stop here, and I will thank you for your attention.
Okay, perhaps there is time for one question because we are a little late. No? Yes, one. Microphone, please. Here. You have it here.
What about the age of the persons involved in a life-threatening event? It seems that you're just giving a number without having differences in age.
You mean in the Tel Aviv?
This, in any statistics, you have to put the age of the persons involved when there is a sudden death or a life-threatening event. What is the differences in age?
Okay, so the 2 individuals who had cardiac events in Tel Aviv were in, the one with the myocardial infarction is in his 40s. He had ECG screening. He had an exercise test performed 3 weeks before the marathon. That was completely normal. We reviewed. That was a maximal exercise test that was completely normal, and he still had a myocardial infarction during the race. The heat stroke victims are even younger. These are usually very fit athletes. They probably were sick just a few days before they participated in the race and developed heat stroke. They were much younger.
Okay. Thank you very much. Thank you. Obviously, you don't believe in ECG screening.